All right, hi everyone. Thanks for taking the time to join. We're going to go ahead and get started because we have a lot to cover and we want to have some time for discussion today. This is a meeting of the Open Oximetry Collaborative Community. For the next hour, we're going to be going through some data, which we think will take about 30 to 45 minutes, and then we'll have time for discussion and questions. If you have questions, please go ahead and put them in the chat, and we'll either try and answer them on the fly or get to them at the end. This meeting is being recorded, and we do intend to post a recording of this session to the Open Oximetry website. Briefly, we're going to be going through a snapshot of testing that the Open Oximetry project has been doing over the last 1.5 to 2 years. We're going to share preliminary findings for about 20 pulse oximeters that we now have testing data on. Share some of the questions that have come up for us, and also would love to hear questions that you have based on the data and have some discussion around what next steps might be. As many of you know, this is kind of the various components of the Open Oximetry project. So clinical studies, our clinical trial has finished enrolling about 700 folks here in San Francisco, and analysis is underway, and hopefully that will be coming out soon. Lab studies is really the focus of what we're going to be talking about today. We have 34 different pulse oximeters under test right now, and we'll share the results of 21 of those during the talks today. This is going to be data from about over 500 sessions. For OpenOx devices, the focus is more about like 257 sessions. So these are participants that have come to the hypoxia lab and undergone controlled desaturation studies, almost 30,000 data pairs in total. And for all of these participants, we've been doing multiple skin color characterization methods, and in total, almost about 10,000 color assessments. The color and pigment assessments aren't going to be the focus of the discussion today. We will have another meeting to share some updates on results specific to skin pigment analysis. The next few slides, I'm going to go through and talk about our desaturation protocol that we've been using for these studies. It's a little bit different than what has been in ISO or FDA guidance and standards documents in the past. And so I'll walk through that and try and highlight some of those key differences. As many of you know, in the past for testing pulse oximeters, generally the cohort size target was around 10 for validation studies. All the devices we're going to be talking about today have at least 24 subjects, if not more, and we'll share the actual numbers for each of the devices. With regard to skin pigment diversity of the cohort, as many of you know, previously there were either kind of no recommendations around that or a recommendation that 2 of 10 of the cohort have dark skin pigmentation, but that wasn't defined. We had been using perceived Fitzpatrick scale 5 and 6 to define that in the past in our laboratory. And for the OpenOx data, we have been using Monk skin tone scale, categories HIJ, and ITA values of less than -30. Here is kind of a table on the right of those criteria. And I will flag that for most of the analysis, we were relying on the ITA values because we frequently had disagreement between the MST on the forehead and the ITA on the forehead, which you can see over on the table how those are estimated to align. We would have challenges around not infrequently around the cutoff. So for example, if you're right at the border of light and medium, you might be categorized as a C or a D, but that might be discordant with the ITA cutoff. And so in that case, we would default and use the ITA. Whatever your ITA was is how we would categorize you into the light, medium, dark. And so for the data analysis I'm going to be sharing today, most of this was based on ITA, but we will share the MST data. Rather than 2 out of 10, we were targeting more than 6 out of 24 to have dark skin pigment as defined by ITA less than -30. And in addition, of those individuals, more than half needed to have an ITA of less than -50. So that was the skin pigment diversity criteria we were using for these tests. With regard to perfusion, in the lab for many validation studies, we would actively warm hands. That was done by either having the subject run their hands under warm water prior to the study beginning, or by putting a heating pad under or around the hand and arm to heat the hands. For most of the data that were collected here, warming was not performed. We also tried to track percent modulation for our participants via our reference oximeter. Obviously not a perfect, not exactly perfusion, but we use percent modulation from a Nellcore PM1000N, which we used as our reference device in all of the subjects. And so you'll see us reporting out percent modulation. That is coming from the same device, the PM1000N. It was on the subject. It obviously was not on the same hand as perhaps the device under test, and it may not have even been on the same, may not have been on the same hand, but we tried to put it on the same hand as much as possible and 1 digit away from the device under test, but that was not always possible. Again, please feel free to add questions into the chat as you have them, and we'll try and chip away at them. Other changes in our protocol, we were using all 5 fingers. So in other studies, commonly we would, depending on the manufacturer's preference, if we were doing a sponsored study, we might avoid the first digit thumb or the 5th digit, the pinky. For OpenOx, we were testing all fingers. We also included testing in the hand on the same side as the arterial line. Part of the reason we were doing all of these things up until this point was trying to get a wider range of real-world clinical conditions. Oximeters are used on many fingers. Oximeters are used on the same side as the arterial line. Oximeters are used in people with a wide range of percent modulation. But I want to flag that that also means that some of the results that we're going to present today differ from what a manufacturer may be reporting, and there are reasons for that. Other parts of our protocol, we were running blood gases in duplicate or triplicate. So we would run a blood gas immediately after it was drawn from the arterial line. We would run it on 2 ABLs. If there was a discrepancy between those 2 samples of more than 0.5% SaO2, we would run it on a 3rd ABL, and then take the 2 SaO2s that were within 0.5%. If none of those 3 were within 0.5%, then that data point would be discarded entirely. We did do shielding on the probes. We did not shield them from ambient light, but we did shield them from each other. And you can see a picture of this. These are like a moldable plastic, and then they are lined with finger shield material that we bought online that's manufactured by Massimo. We cut that and lined the inside of the plastic. And again, just shielding between devices, not shielding from ambient. When we were using reusable sensors, we were changing those every few months. And then during the studies, we were, as frequently as possible, reassessing probe positioning. I will say this was a significant factor that we saw, that keeping all of the probes in line and appropriately placed is challenging. In many cases, more so with devices that had a cable attached to them rather than these standalone fingertip devices, because the cables frequently would pull. And so we were taking a lot of care, as much as we can, to try and keep the cables in line with the finger. All devices that we're going to be sharing data had at least 500 paired SpO2, SaO2 readings. Another piece of cohort data, not new, is just trying to make sure that at least a 1/3 of each cohort had gender representation. Our desaturation protocol, which is available online through this QR code with all of the rest of our protocols, which will have a bit more detail than what I'm going to go through here, are available online. Quickly, we do 2 desaturation runs. In each of those saturation runs, there are 3 plateaus, one in the 90s, one in the 80s, one in the 70s. This gives you a sense of what we're looking at. We wait at least 60 seconds after a plateau change. On average, though, it's more like 2 to 3 minutes. And in patients with lower perfusion, not infrequently, it's 4 to 5 minutes for plateau stability to be achieved. We're not including 100% SpO2s in the analysis. And then we do analyze to make sure that the distribution of data points within each of these 3 plateaus is balanced, even when looking at the cohorts by skin pigment cohorts. In terms of plateau stability, again, the greater than 60 seconds is the minimal. We're also tracking calculated saturation based on end-tidal oxygen and tidal CO2. We're tracking SpO2 from our reference device, the PM1000N, and then we're tracking the SaO2s from our ABLs. All of these feed into our LabVIEW system and in real time give the study investigators data on the stability of the plateau, including whether or not to continue sampling or to wait for more stability. This is happening in real time. It also happens once data are collected to post-process and go through and eliminate data points that were taken during instability. More details on our plateau stability and data cleaning protocols can be found online in the data protocols that I linked to here. For a session to be kept, it had to have at least 6 usable stable SpO2, SaO2 data pairs in each of the deciles, 70 to 80, 80 to 90, 90 to 100. It needed to include data pairs at the low and high end. We, in the past, had used 70 to 73. We extended that to 67 because not infrequently we had stable plateaus just below 70, which we felt like were useful and achieved the same goals, and avoided having to throw out sessions because it was less than 70. Again, we tried to ensure that the data was evenly distributed by the deciles and the skin pigment groups, and check it out online if you want to see more about that. These are the devices under test right now. We've got about 40 to 50 devices that are at various stages. 34 are getting close to being done, and 21 of these we're going to present today. On the website, we've pushed a lot of data in the last few days. So at openoximetry.org, there's the standard performance data. So ARMS from the manufacturer when we can find it. The ARMS that we are calculating, our max steady cohort. So for this particular device at 51. And when you see a cohort here reported, we're reporting the max cohort that met the criteria for skin pigment diversity and all of these other things that I've mentioned to you. So in many cases, we've tested the device on many more than this, but the max cohort size that we could create that still met all the criteria that we were trying to achieve is what's reported here, including the percent. We report the percent of the study cohort with dark skin pigmentation as defined by ITA less than -30. And now on the website for many more devices, you'll see a lot more of this extended performance information. This includes a visual representation of the forehead for each of the subjects, what that looks like. Each of these squares is the Monk skin tone scale category for that subject that was assigned by the clinical research team. We report the percent of the dark cohort, the cohort with ITA less than -30 or Monk HIJ, who also had ITA less than -50. Again, our target was to have at least half meet that criteria. And then we start reporting, the metrics for skin pigment bias. You'll see differential bias on here. We have a number of different plots that we are trying to report. And then we're also reporting absolute bias here for different skin color cohorts, as well as different SpO2 thresholds. Here we do report the percent of the cohort that had low percent modulation, which we defined as less than 1. And we try and report here, we explain that a little bit more. So each of these eyes in a circle, you can hover over and get the details on exactly what you're looking at. In a minute, I'm going to hand this over to my colleagues who are going to share some of those data. And I want to emphasize that the data that we're sharing with you right now are data that have been obtained in the hypoxia lab using the protocols that we've mentioned, but these are imperfect data. We are trying to learn from the data. The protocols are different than what, in many cases, the manufacturers have used. And so please interpret it with that lens. And so with that, I'm going to go ahead and hand over to my colleague, Caroline Hughes. Caroline was a clinical research coordinator here at the hypoxia lab and part of the open oximetry project. She's now a medical student in St. Louis. And has been active in a lot of our data analysis. And after Caroline speaks, we'll be handing over to Danny Chen, who is the team's statistician. Danny's been with the group for over a year and has been designing a lot of our data collection systems and doing a lot of the data analysis. And a big thanks goes to them, as well as Ella Benke, Lily Ortiz, and Renee Zamora, who are part of the clinical research team, currently doing studies in the lab as we speak. So with that, I'll hand it over to you, Caroline.
Thank you, Mike. Hello, everyone. I'm Caroline. So as Mike mentioned, we tested 21 devices in this cohort. Of those devices, I'd like to point out that 17 of them had FDA 510(k) approval. So we would have expected that those 17 devices would have met an ARMS of less than or equal to 3% because that is part of the 510(k) approval process. What you will see here is that of our 21 devices, we had 10 devices that met an ARMS of less than or equal to 3% with our testing. Blue text on this screen will indicate which devices had 510(k) approval and also met an ARMS of less than or equal to 3%. You'll see we had 2 devices indicated with the black text that actually did not have 510(k) approval, but still met an ARMS of less than or equal to 3%. A couple of things to highlight from this slide. You'll see the Nonin Copilot as well as the Shenzhen PC60NW fingertip pulse oximeter are at 2 very different price points. However, they had our highest ARMS performance. So we were encouraged to see that devices across a range of price points can still achieve high ARMS performance. Additionally, we wanted to point out, as Mike mentioned, we were looking at the percent modulation of our reference pulse oximeter for these cohorts. And you'll see that with the Nonin Copilot, as well as the Shenzhen Creative fingertip pulse oximeter, there was a high percent modulation in our reference pulse oximeter for their cohorts, indicating that these cohorts had a high level of perfusion. So we wanted to also point this out to indicate that as we continue testing these devices, we may see performance changes if the perfusion measurements go down as the cohort is continued to be tested. Next slide, please. And yes, and then just to emphasize again on that last slide, sorry, that we see 8 of our 17 devices that had 510(k) approval meeting a ARMS of less than or equal to 3%. All right, next slide, please. All right, so here we see the remaining devices. 11 devices had an ARMS of greater than or equal to 3%. Once again, devices listed in blue are devices with 510(k) approval. We would have expected these devices to meet an ARMS of less than or equal to 3% in the testing because that is part of the 510(k) approval process. You'll see that our best and worst performing devices in this cohort, the Bestos BT710, as well as the American Oxygen LK87 devices, did not have 510(k) approval. One other thing to note is that the Masimo MightySat, you'll see it has stars next to its name. We noticed that when we were looking at different ways to break down our cohorts, if you took out the subjects that tested the Masimo MightySat on their thumb and only looked at the subjects where it was tested on other fingers, the ARMS actually went down from 3.28% to 2.44%, indicating that it would be an ARMS less than 3%. If you only looked at when the device was not tested on the thumb. So we wanted to also note that as you break down the cohort in different ways, we were noticing for some devices, particularly with the Masimo MightySat, the ARMS did change. Next slide, please. So here we look at ARMS broken down by the different skin pigment color categories that Mike had mentioned earlier. You'll see on the left are those 10 devices with an ARMS of less than 3% overall. And then on the right are the 11 remaining devices that had an ARMS of greater than 3% overall. For many of the devices, we see a trend where the subjects in the darker skin pigmentation category had a higher ARMS than the subjects in the lower skin pigmentation categories for a device. And for 3 of the 21 devices, that difference was statistically significant, indicated by the asterisk on this slide. Next slide, please. Here we look at ARMS in the higher oxygen saturation category of 85 to 100%. Again, on the left are the devices that overall had met an ARMS of less than 3%. And on the right are devices that had met an ARMS of greater than 3%. Again, for many devices, we see a trend where the ARMS for the darker skin pigment category is lighter than, or is higher, sorry, than the lighter skin pigment category. Those are indicated by the light blue asterisks. However, we did want to point out that for one device, we actually saw the opposite, where the lighter skin pigmentation category actually had a higher ARMS than the darker skin pigmentation category, and this was statistically significant, only for this oxygenation saturation range of 85 to 100%. And that was the Choice Med device on the left that you see there. Next slide, please. Here we look at the lower oxygen saturation range in ARMS. Again, for many devices, we see that the ARMS is higher for subjects in that darker skin pigmentation range. And for 4 of the 21 devices, we saw that difference between the darker and lighter groups to be statistically significant of higher ARMS. Next slide, please. And then here we will look at mean bias. Danny will continue this discussion on her slides, but we also wanted to give a visual representation. For many of our 21 devices tested, we saw positive bias overall, meaning that the pulse oximeter's SpO2 was a higher number than the subject's actual SaO2 blood oxygen levels. You can also see that for 10 of the 21 devices, so almost half of our devices, we actually saw that there was a statistically significant difference of more positive bias for subjects in the darker skin pigmentation range than in the lighter skin pigmentation range. Those devices are marked with the light blue asterisk. And then you'll see that for 2 devices, we saw the opposite, where there was actually statistically significant more negative of the positive bias for subjects in the darker skin pigmentation range than the lighter skin pigmentation range. And we'll look at that now broken up across the different oxygenation saturation ranges on the next slide. So here again is the higher oxygenation saturation range of 85 to 100%. You'll see that in this range, we saw 7 of the 21 devices showing positive bias that was greater in the darker skin pigmentation group than in the lighter skin pigmentation group. Again, overall, for many of our devices, we were just seeing positive bias no matter the skin pigmentation group. And then the 2 devices marked with the dark blue asterisk showed the opposite of that trend noted above of more positive bias, or in this case, more negative bias for the darker skin pigmentation group than the positive, or than the lighter, sorry. Okay, and the next slide, please. Okay, and then here again is the lowest saturation group of 67 to 84% SaO2. For this range, the positive bias was very pronounced for many devices. And you'll see that for 11 of the 21 devices, we saw more positive bias in subjects in that darker skin pigmentation category than the lighter skin pigmentation category. And this was statistically significant. And then again, 2 devices that showed the opposite of this trend. And Danny is going to continue the discussion on the next slide.
Thanks, Caroline. Hi, everyone. My name is Danny. So we were interested in seeing if the bias between the dark and light skin color groups are significantly different. And this table shows the mean bias of the dark and light skin groups, the difference of their means, and the p-value that suggests the significance of the difference at the SaO2 85 to 100% range. So looking at this table, we see 9 devices with significant bias between dark and light skin color groups, highlighted in yellow here. And if we look at the difference in means, 7 of the 9 devices highlighted in orange here have positive differences, suggesting that they have more positive bias in the dark skin color group. And we were also interested to see if ARMS is a predictor of significant difference. But if we look at the last column, which shows the ARMS of each device, we see both devices with ARMS less than 3% and larger than 3% have significant difference. So ARMS is probably not a predictor of significant difference in biases between skin color groups. Next slide, please. So this table focuses on SaO2 at 67 to 85% range. 13 devices have significant differences in bias between the 2 skin color groups, and 11 out of the 13 devices suggest more positive bias in the dark skin group. And again, we don't see a trend of ARMS associated with significant differences. Next slide, please. Next, we'll be talking about the ITA-derived differential bias, which we can think of as regressing to estimate the predicted bias between 2 subjects with an ITA difference of 100. So visually speaking, The example here plots the mean biases versus ITA in one of the two specified SAO2 ranges. Each of the purple dots represents a subject's mean SpO2 minus SAO2 difference within the range versus the subject's ITA at the device probe site. The dashed line in red represent the linear regression line from these data, and the two dashed lines in gray represent ITA of minus 50 and 50. The differential bias can be viewed as the absolute difference between values of the regression line at ITA of minus 50 and 50, which in this example is approximately 1%. Next slide, please. So here we show the mean bias versus ITA plots of 3 of the devices that have the lowest ARMS at the top and 3 that have the highest ARMS at the bottom. From these scatter plots, we see the dots which represent the mean biases of a subject clustered around mean bias of 0 for the best devices, while the worst devices have the dots cluster further away from the mean 0. However, except for the devices in the lower left, all other devices have a fairly flat regression line, which suggests that the differential bias between ITA of minus 50 and 50 is probably not big, maybe within 0.5%. And this shows that some of the devices fail the ARMS less than 3% check, but were still able to pass the differential bias test. Next slide, please. Here is the same set of devices at SAO2 67 to 85% range. We expected to see a larger slope from the regression line in the lower saturation range, but again, the low ARMS devices have mean biases clustered around 0, and the higher ARMS devices have mean biases further away from 0. But all devices, except for the one in the lower right, have relatively flat regression lines. And again, this tells us that the ARMS performance is probably not a predictor in the device differential bias performance. Next slide, please. This table summarizes the device's differential bias at the two specified SAO2 ranges. This table looks at the 10 devices that passed the ARMS less than 3% check, and the ones in blue again indicates 510K approval. The second and third columns show estimates of differential bias in the two SAO2 ranges. And the last two columns indicate the FDA and ISO thresholds. Of the 10 devices passed currently proposed thresholds on both SAO2 ranges. However, note that some of the devices have a wide confidence interval. For example, the Beijing choice on the 3rd row and Nanin 9590 oximeter on the 5th row, suggesting that these devices may have high variability in biases across ITA. Next slide, please. Here we look at the performance of the 11 devices that did not meet the ARMS less than 3% check, but only 4 of them had the absolute differential bias fall outside of the FDA's thresholds, and only 1 didn't pass the ISO's threshold. And we also have devices that have estimates within the threshold, but with very wide confidence intervals. For example, Massimo Mighty said on the 3rd row, and device from Shenzhen We Live Medical on the 4th row. I will hand it back to Mike.
Thanks, Danny. And thanks everybody who's putting comments in the chat. I think we're going to have a good amount of time for some discussion here, so please keep that discussion going. There are a couple additional analyses we're going to share and then some future directions, and then we'll have discussion. Caroline had already alluded to this issue of like, does finger choice make a difference? We have reviewed all the literature for the devices that we've been testing and note that in some cases, the manufacturers specifically state either don't use the thumb or don't use the pinky, or more commonly, there's a recommendation made to use second, third, and fourth digits preferentially, but not necessarily to avoid the thumb. However, we received inquiries about this, and so we decided to run the analysis ourselves. We redid the ARMS analysis with thumb included and thumb excluded. And for most devices, we did not find a big change in performance, but these devices did have a change of greater than or equal to 0.2 in ARMS. Most of them, the performance got worse, and in one, the performance got better, which was the MightySat, as Carolyn had alluded to. Another analysis that we did was bootstrapping with our cohorts to try and create the cohort of 24 with the balance of gender, diversity of skin pigment, all the other criteria that I had mentioned at the beginning. So for example, at the top left here, we had a device that had a total number of 51 participants that we had tested it in. We chose and created cohorts of 24 from that 51 over and over again. We created 100 cohorts and calculated the ARMS. The purpose of doing this was try and see if we could create cohorts that make the device look markedly different. Here you can see for the top row, most of the devices stay below this ARMS threshold of 3%. And if we go to the bottom here, the worst performing devices, so best performing devices top left, worst performing devices bottom right by ARMS. At the bottom right, these devices kind of no matter what cohort you put together, they always look bad. No matter what cohort you put together, these devices always look good. But there are devices in the middle where depending on what cohort you put together, the devices can look like they've got an ARMS of closer to 2% or an ARMS of closer to 4%. And so this is an area of future investigation looking into these and trying to understand what it is about individuals in this cohort or these specific devices that is causing that, to try and ideally design a protocol and test that where we get better separation, where this isn't possible to create cohorts that can sort of make the ARMS look different than what it may be much of the time. We also did some bootstrapping to try and figure out the impact of different cohort sizes on ARMS. So the only two devices where we have lots of data are for two devices that we commonly use as reference devices, the PM1000N on the left and the Masimo Rad97. One of the comments in the chat asked what probes we use. For all of these devices, we are using and reporting here reusable finger clip style sensors. The reason we chose that was because of relevance to global populations that may not have access to disposable probes. And then secondarily, for cost reasons. So these are with two wavelength disposable probes, two wavelength reusable probes. We do note on the website the probe that was used for each of the devices, and especially if that is different. We do have device testing underway with the Rad97 and the PM1000N with multiple other probes made by those manufacturers, and we hope to share those soon. So here with the bootstrapping, the cohort in total, we had about 105 subjects that we had tested with the PM1000N. When we try and create cohorts of 10, 20, 30, 40, 50, you can see the effect or the ARMS that we calculate from the bootstrapping for each of those cohorts. See it kind of like dropping off significantly here, and then more or less remaining stable. A lot of reasons why that could be, and we can discuss that in a little bit. And then same thing for the Rad97. Trying to look at our data in a lot of different ways to get at this question of what is the appropriate cohort size for these tests? When do we have kind of marginal benefit of diminishing returns from increasing sample size? And so that's sort of the intention of a lot of the analyses that we've been trying to do here. So some of the overall takeaways, a lot of the devices that we tested that did have 510Ks did not pass with our protocol that we used here. Doesn't mean that the data that they submitted with the 510K isn't real. It just means that we used a different protocol, and TBD to decide what has the most relevance for real-world populations. We did see more positive bias in darker skin pigment groups at lower saturations, but sometimes we did see negative bias as well. And then all the devices that had ARMS less than 3% also passed the differential bias criteria. And perhaps for discussion is the thresholds for this differential bias criteria and the utility would be things that we could talk about a bit more. Some of the studies that we have ongoing right now, as mentioned, we're trying to test more devices. We're trying to test more devices with different probe styles, including multi-wavelength devices, ear, nose, forehead, other types of probe designs, and hope to be able to report that in the coming months, although these studies are taking quite a bit of time to do. We did measure finger size and other physical characteristics of the patients, BMI, et cetera. So we're going to be trying to do analyses with other, adding in these other variables into the analysis to try and look for effects. We collected raw pleth using a custom-made device that we have on the website, kind of the instructions for how we did that and how we collected those data. We're trying to look at the raw PPG for each of these sessions, for each of these devices, same people, and try and see if we can understand a little bit more about the performance by looking at the raw signal from an independent device that was used on all of them. We're also trying to put together cohorts of outliers, subjects who've come to the lab and consistently devices for whatever reason have more bias in those participants to try and understand that a bit more. As mentioned, the Equiax clinical trial is completed, so hopefully the results from that will be coming soon. And then one challenge remains, that is the diversity of our study cohorts being reflective of global populations. For a number of reasons, that remains a challenge. And so we are actively fundraising to open a lab in East Africa with partners in Uganda. And so please reach out if you have interest in that, and hope to be able to share some updates on that in the coming weeks and months. These are some of the questions that we wanted to pose to the group, but before I get to that, I'll leave with that slide. I just wanted to thank the team. There are a number of people who have contributed at UCSF, at other institutions, Ellis Monk, Leo Shmulevich, many others. Really has been great working with everybody and appreciative of our funders and supporters for the project. So with that, I'll go back to these questions, but happy to discuss anything that's in the chat. And so if folks want to either put into the chat or raise your hand, we can start some discussion here at this point. And thanks very much for your attention. And Fifi, I don't know that I can see anybody's hands raised. But if anybody who has discussion in the chat, or if you want to chime in, please go ahead. Sandhya, since you're the last discussion chat here, do you want to start off? Do you want to unmute and ask your question?
Yeah, sure. Thank you for sharing the data so far. It looks great, and it's nice to hear that you will be incorporating different styles of devices. I was interested in seeing if you would be performing any analysis to observe differences between device types, maybe between device types of different probe reflectivity, like the cloth disposable style ones versus the non-cloth ones.
Yeah, thanks for the question. So for some of the devices we are, in particular, our two reference devices, and we have two other reference devices we don't yet have large enough cohorts for, which are a Philips device and a Nihon Kohden device. But for the Masimo Rad97 and the PM1000N, we are testing both of those in multiple probes, including disposable, the wrap style disposable probes as you're describing, as well as reflectance forehead, and then also for some of the multi-wavelength, greater than 2 wavelength probe types. So we hope to be able to share that as well. I see from someone here in the chat, are any of the pediatric trials complete? So we aren't, so there's a pediatric clinical trial at Stanford that I don't have data, that I have not seen data from that trial yet. That's the only pediatric trial that I'm aware of. So I don't have updates on that. Sarah Brown, I see your hand, and then I'll go to Jack after that.
Sorry, I was taking a while. But Mike, could you let me know who's the pediatrician at Stanford that's involved in this?
There are several. Chris Almond is one of the PIs. But if you want to link, send me an email. I'm happy to link with you. Also of note, we have a clinical trials subgroup of this collaborative community that meets and shares updates from the clinical trials. So if you are interested in clinical trials, you can sign up for that on the Open Oximetry homepage. There's a form, and then we'll invite you to the next meeting. That might be a great way to connect.
Awesome, that'd be great.
And then somebody in the chat says that there are 3 other pediatric studies ongoing. There are a couple that were just getting started. One is in pediatric cardiac, like in a cath lab patient population. There's one at Rush, but I'm not aware of studies that are done. And then Cape Town data. Whoever's typing on the P's, do you want to unmute and just share your updates?
Sorry, I was actively driving.
Oh, no problem.
Yeah, I was just curious. This is Shibata Hooley. I'm at Texas Children's Hospital. Hi. And yeah, I think I've like asked this question at every one of our meetings if there are any updates on pediatric specific data. And yes, we've started studying a couple of different types of pulse oximeters in Cape Town, but are not yet ready to present preliminary data. We'll be starting a prospective study here in Houston any day now. And then I know about the cath lab focused study that you had mentioned before, but it's good to know that there's one happening at Rush. And it would really be great if people were interested, if the pediatric investigators could perhaps have a sub-meeting to talk about kind of points that people have learned from starting these studies, because we all want to make sure that we're collecting high quality data across all of our sites, because this question will only be answered with multiple different types of studies using different types of devices and different types of patient populations.
Thanks, Shota. So sorry, I forgot about y'all's study. I think it's a great idea. We're happy to, we can link up and happy to try and host it as like a topic of a subgroup meeting and have some of the adult folks join in too if useful and focus it on peds. And then I see Desiree Conrad, who's also leading the Stanford study, is in the chat as well for those who are interested in that. Thanks, Desiree, for chiming in there. Jack, over to you.
Mike, I mostly wanted to compliment you, and I've got a bunch of particular compliments in the chat. I think I'm going to make a comment that has the option to be a question if you choose to respond, although I suspect you will not. I did note the discrepancy between finding seemingly very large differences across race and skin tone in the individual levels in your individual device testing, with nonetheless the fact that essentially all of those would have passed the proposed FDA standards, which seems to me to be a substantial concern that the FDA standards were built on technical feasibility rather than safety, and raises the concern that they may still let through potentially unacceptable levels of racial differentials. I guess my question to you is that consistent with the interpretation of your data? If you wish to comment on the policy implications, I will leave you the floor, but not force you to. Over.
Thanks a lot, Jack. I can try and comment briefly, and anybody on our team or otherwise who wants to chime in as well. I don't think we know what the right thresholds are. I think especially in the 75 to 85% range, which is where we're seeing bigger differences. I believe that you're referring to some devices that are like 2%, 3.5% differential. That feels more concerning in that range than in the 85 to 90%, where generally all the devices were 1% or less. I think an outstanding question that we still have is 1% in the 90% range still too much at a population level, like during a COVID pandemic where you're triaging patients or deciding on therapy at scale? Would you see healthcare disparities still even with that? So I don't know that I could comment more on that beyond that. We don't know. I'm not sure. I don't know if anybody, Danny, Tyler, others on our team want to weigh in on that. But active area of discussion. I mean, we talk about it all the time. And I think it's going to continue to be an active area. I will say, I think right now there is no bar. And so for regulatory to put something on the map is an important step, and it's going to take more data and more time for us to figure out how, what's the optimal. Also, what is the optimal while balancing marginal benefits to global populations? Are we going to, I think that is a real concern of potentially limiting access, raising costs for communities that are already having trouble getting access to pulse oximetry, where this wouldn't result in health and healthcare disparities in those settings in the same way that it might in certain high-income countries, for example.
Mike, why would an equitably functioning pulse oximeter intrinsically be more expensive?
So I think some of the arguments that are being made around, well, it wouldn't necessarily. And I think our data show that there are some devices that are relatively not expensive that don't seem to have the issue of differential bias. I think the concern is if there are a couple things, and I don't know that I could summarize this in a minute, but we're hearing a lot of calls, for example, of, well, all pulse oximeters should be multi-wavelength. Let's just make them all 8 wavelengths because that seems to be better. And if we do that, then we won't have any problems at all. Or we're hearing companies who have new technologies that may have solved this problem. Or we're hearing, if regulatory tests have such huge requirements that there's a huge cost change. A study goes from being $50,000 to $2 million per device or probe. That's something we're going to pass on to consumers. Those are like 3 scenarios that we hear. I think there are some reasonable points in there, but I don't think that is to say that there's something inherently where we can't have equitable devices without raising costs. I don't think that is unattainable, but I do think some of the strategies and concerns out there could result in increased costs, if that makes sense. But maybe we'll come back to that if we have time. Keith, I see your hand. You're next in line.
Hi, Mike. Thanks for presenting this data. You and your team did a great job. I was looking at your plans for future studies and wondering about your thoughts around the low perfusion cohort in terms of the methodology you will consider using for those assessments. Would it be localized cooling versus whole body cooling versus tourniquet versus maybe some sort of drug-induced perfusion? What are your preliminary thoughts?
Yeah, our preliminary thoughts, we are trying to recruit without having to do intervention. So we do have a wide range of perfusion or pulsatility, amplitude, percent modulation. We have a wide range in our cohorts at baseline. And so we're trying to identify from our cohorts, which are often subjects who will come back to the lab, trying to identify pools of people who generally have percent mod on the low end and see if we can put together cohorts in that way. That would be kind of our preferred, easiest, unaltered. The other would be, we would do with like forced air cooling of the extremities is the other thing that we've done. We have tried all the other methods and outlined some of those online, but for a variety of reasons, we've tried to do it in that way. But there are many ways that this can be done. I think there are certain ways that it can be done that have introduced other problems. So like tourniqueting or causing any kind of venous congestion in the extremity can cause impact on the performance of the accuracy of the signal in an unintended way. But many ways to do it, but that's the way that we are looking at doing it. Would be naturally recruiting these cohorts and then forced air cooling.
Okay.
Sarah Brown, I see your hand up. I don't know if that's from before or not. Thanks, Keith.
No, it just, how are you measuring perfusion, Mike? I'm sorry, I'm not I'm an ordinary physician, so I just wanted to understand, how are you gauging the perfusion when you do the testing?
I'm an ordinary physician too, sir. Makes you feel any better. It's an active area. So we've engaged with a number of researchers that specifically work in, basically peripheral arterial disease and other devices that target PAD and other things that measure perfusion. We are talking about like a surrogate, basically. We're talking about percent modulation as measured by an oximeter or by our own kind of like PPG device that we've created in the lab. We see percent modulation from that. So it's a very crude surrogate. We use the word perfusion quite loosely, but that's not actually what we're measuring necessarily.
Thank you. Great work.
Other comments, I'll try and just work my way up here. Probe variability, Jeff, thanks for the comments. Yeah, we totally agree. And we do see that effect, same device, different probes. So we are trying to do some more work digging into that. Ash, thanks for joining. See your hand. Go for it.
Thanks, Mike. Just clarification. I'm sorry you said this during the presentation. I missed it, but what is the difference between the perfusion index, especially the ones that are reported on some devices from the manufacturers on the screen versus the modulation that you're reporting to try and make as a surrogate for perfusion? Well, what's the difference between that and how can we interpret the two?
That's a great question, Ash. I don't think I could answer it completely accurately because I don't, well, I can tell you how I understand it. My understanding is that the manufacturers report it differently, and that some manufacturers would tell you that what they put on their machine, they process their PPGs differently. So like what you visually see might not be raw. It might not actually reflect, does it have high or low pulsatility amplitude? Like, and then if they do spit out a number, which not all do, that number is not the same across the devices. The experience that I can refer to with, for example, we pull percent modulation off of our PM1000N, and we pull perfusion index off of our RAD97 from Masimo. We found like a correction factor that makes them behave or seem very similar, but we've been told by the companies that they are in fact not the same, but we don't have access to those formulas. So I don't know if that answers your question, but I guess I would sum it up as it's not necessarily apples to apples, and it's not necessarily raw percent modulation depending on what device you have based on the information that I have available to me. Our research raw PPG device, which is not what I reported here, does calculate percent mod in a way that is non-proprietary, and we try and share the formulas. And so we're hoping for research purposes, we can try to use that so that others can reproduce. Yeah. Thanks for the question, Ash.
That's super helpful. Thanks. I have one other smaller question.
Please.
Do you have any indication of the perfusion that you're measuring in the lab versus anything that's measured clinically on an actual patient? Like, what is there a difference between those two in terms of accuracy, in terms of what they represent?
We will have data from the ECRAC clinical trial about how the perfusion index reported by some Masimo devices which are used in that trial correlates with things like vasopressor use, blood pressure, things like that. But so many caveats to interpreting that. The best example I could give is we have healthy volunteers who come into the lab all the time with incredibly low perfusion index as read by Masimo, or pulse percent modulation as read by Nellcor, and they're obviously well and not on pressors and have a normal blood pressure. So and good perfusion by systemically. So hard to say, but we will share what we have on that as soon as we can.
Thanks. Great job with this stuff.
You're welcome. Thanks a lot. Bev, over to you. Thanks for joining.
Thanks, Mike. Can you hear me okay?
Yep, we can hear you great.
Great. I have a question going back to the regulatory piece. A bit surprising how many devices had 510K that weren't meeting the accuracy bar. So sort of a two-part question. Have you checked whether the devices have the EU CE mark? And I'm curious if there's any difference in how many are meeting the bar through a different regulatory framework. And this is coming, from a procurement agency where these market clearances are a huge part of our product selection process. And then the second piece is, and I'm not a regulatory expert, but the 510K approval is based on a significant equivalence to a predicate device. So I don't know how it works with pulse oximetry, but are these devices getting their market clearance based on the accuracy of the predicate device, or do they have to submit new data for their specific device? Maybe this is not a question for you, but maybe for the broader community, just like how does that work when there's this sped up pathway to regulatory in the US via this predicate device route? Thanks.
Thanks, Bev. Yeah, I don't know that I could answer it entirely. A couple of quick responses would be, again, just highlighting the protocol we use for the testing of the results that I showed now. It is different in many ways from what the manufacturers used when they submitted it originally. And so, there are reasons why it may be different. Caroline has just put in the chat the devices with CE markings, which would most likely indicate that they are compliant with ISO 8601. So you can see that there, and we'll try and indicate that on the website as well, which devices have that. I don't know if anybody from FDA is here who would be able to comment on this question of 510K and using the predicate clearance. Is anybody from
Yeah,
FDA here?
this is Kumo. I can go.
Hey, Kumo.
Great question. So we, irrespective of the 510K pathway, for any new pulse oximeter, so significant changes in the electro-optical pathway or algorithm that classifies it as new, would be asked for clinical data, controlled desaturation lab data, to meet the performance requirements or recommendations on our 2013 guidance. Hope that answers the question, Bev.
Thanks, Kumo.
Yeah, thanks. Sorry, I was muted. Thank you. That's helpful.
Josh, you ask, did the requirement for very dark ITA less than -50, is that indeed necessary? We did run an analysis of breaking that cohort out. So instead of showing light, medium, dark, we had light, medium, dark, very dark. The catch was those cohort sizes were so low, so small, we did not see an effect there. We have not run it excluding those. We could do that. I think that's kind of in our future steps. So happy to maybe circle back with you as we dig a little bit deeper into that. I will say we do have a study that's ongoing led by Dr. Ronald Bisagarawa and Dr. Fred Balamba in Uganda, collecting data from Uganda, but also more broadly across the African continent. And we are seeing that, ITA -50 is extremely common. And from a standpoint of global representation, we think it makes sense. But in terms of looking for effect on oximeters, TBD. So happy to share with you as we dig deeper into that. So if we've got just a couple more minutes left. Yeah, thanks, Josh. I will say the other thing, we've pushed some data to the web. We are constantly updating. So, device performance data may change as we are testing in more cohorts, doing other analyses. We are also, thanks to Nick Fong, Tyler Law from our team, we have a raw data set that we put on PhysioNet. We're in the process of doing a big update to that will have a lot of this new data in there. So stay tuned for those who are interested in access to this raw data. WIM, ITA -50 common, multiple sites, forehead and dorsal distal phalanx are the two sites where we're measuring in that particular study. I'm trying to go up through the chat, but please raise your hand if you had questions that we haven't gotten to yet. All right, well, in the interest of time, I think we'll go ahead and wrap and end on the hour. For those who have questions that we didn't get to, please reach out directly to us through the website. Happy to answer questions. We will be following up with some subgroup meetings of the collaborative community to try and dig deeper into some of these other studies. Subhita and others interested in the pediatric question, happy to circle back on that and focus one of the clinical trials groups discussions just on that. But thank you all very much for your time. And again, a big thanks to our team here and our supporters. Everybody have a great day. You can find this video on the website in the next couple hours. Thanks a lot.